our first IPRC webinar for our fall webinar series. Many of you, I'm sure, are familiar with the UNC Injury Prevention Research Center, but the elevator speech for IPRC is that we are one of 10 CDC funded centers. We're one of only 2 that have been continuously funded for over 30 years. We're transdisciplinary, and we do all sorts of educational outreach and research activities around injury and violence prevention. This webinar series was kind of dormant during the pandemic, and we're really excited to be starting up with our educational offerings as part of the center. Our goal here is to showcase IPRC-related and collaborators' research and outreach and training activities, as well as to initiate and foster connection and collaboration among injury and violence prevention practitioners and researchers and students and faculty across the state and across the nation and across the world. Sierra's going to be telling you a little bit more about upcoming webinars. They are the second Wednesday of every month through May of 2023, and we'll have different presenters and topics each month. And this month, I'm going to segue right into the introduction so that we have lots of time for the presentation and Q&A. This month, we're very excited to have Dr. Orrin Ware as our featured speaker. He is a brand new assistant professor. We just found out that Dr. Ware has been here for 3 months and 2 days here in Chapel Hill. He's a faculty member and assistant professor at the UNC Chapel Hill School of Social Work. Before that, he received his Ph.D. from the University of Maryland School of Social Work. And after that, he completed a NIDA T23 postdoctoral fellowship at Johns Hopkins University School of Medicine in the Behavioral Pharmacology Research Unit. Dr. Ware's research examines adult substance use disorder treatment, especially among those who have co-occurring mental health disorders. And today, as Ciara mentioned, Dr. Ware will be presenting on his research examining opioid withdrawal severity through a longitudinal study. So I'm going to pass it to you, Dr. Ware. Welcome.
Thank you so much, Dr. Morocco, for that amazing introduction. So first, let me just share my screen. Here we go. Okay. All right. So, all right. Can everyone see my screen? Perfect. Okay. So again, I can't do justice beyond that amazing introduction, but my name is Dr. Orrin Ware, and I am an assistant professor here at the School of Social Work at UNC Chapel Hill. And the title of my presentation today is Examining Opioid Withdrawal Severity. So I want to first just provide some context about how I became interested in this area. So I worked as an applied public health researcher, conducting HIV tests, providing HIV results, and referring folks to treatment in several different settings. And one of those settings was actually a substance use disorder treatment facility. And then later on, I became a licensed clinical social worker, working in West Baltimore. And I would like to just kind of take this moment here to see if, if you could raise your hands if you've ever seen either the HBO show The Wire or The Corner. Anyone? Any show of hands? You can click on the reaction button. Okay, I'm seeing a couple hands and I'm seeing some thumbs up. So The Wire is just such a realistic representation of substance use disorders and substance trading in West Baltimore. Essentially, there's a high level of socioeconomic issues that many groups face in West Baltimore. And working in such an intense setting, I was able to see firsthand how treatment works, right? And so I worked as an outpatient treatment group leader. Then I also worked in residential treatment. I was one of the first faces people would see when they would enter treatment. Then I also worked in the crisis stabilization unit. So the crisis stabilization unit is basically a short, brief period in which someone who is going through opioid withdrawal receives treatment. Oftentimes when someone received Narcan after an opioid overdose, I was one of the first faces that they would see in this crisis stabilization unit. And in this setting, I had a chance to observe the intensity and the variation of opioid withdrawal severity. So I thought, and I became a bit curious about the intensity of opioid withdrawal severity, which is the topic of the study today. But to provide some background on this topic, so about 2.7 million people in the US have an opioid use disorder. And if someone has an opioid use disorder, one of the potential risks if they stop taking opioids is to experience withdrawal. And so withdrawal is a series of symptoms that may be really uncomfortable, and that may include nausea, diarrhea, vomiting, etc. But there is some evidence to suggest that there are differences in withdrawal severity between different individuals. And some of these different characteristics that patients may have when entering treatment may create differences in opioid withdrawal severity. So there are some studies that have identified gender-based differences in treatment presentation. So studies have shown that women are more likely to have barriers to actually entering treatment compared to men. And then studies have also shown that chronic pain, which is more likely to be experienced by women, is also associated with greater opioid withdrawal severity. So it became important kind of looking at the literature that understanding more about the role of gender and chronic pain on opioid withdrawal severity for individuals entering treatment is an imperative. So that brought me to this amazing objective, this question. Are there gender-based differences in opioid withdrawal severity from treatment intake to 7 to 9 days later? And so to answer that research question, there was a sample of 1,252 adults with an opioid use disorder who were being treated for an opioid use disorder, entering 8 different treatment facilities. And the data were provided by the VISTA Research Group. And since this is a longitudinal study, of these 1,252 adults, there were 2,992 repeated outcome measures. And so the data were collected at 4 different time points for the outcome measure. And again, the outcome measure was withdrawal severity. And so to kind of answer that research question, a mixed regression analysis was conducted with the outcome being withdrawal severity. And that was measured on a Likert scale measure, which had a range of 0 to 36, of 36 being representative of the greatest opioid withdrawal severity, and 0 being representative of no opioid withdrawal severity. And so on these 9 items, individuals would rate how much or how little they were experiencing specific symptoms. And these items ranged with response items from not at all experiencing these symptoms to extremely experiencing these symptoms. And so 36, again, represented the greatest opioid withdrawal severity. So in the mixed effects model, age, substance use severity, gender, chronic pain, substance of choice, and polysubstance use were added as predictors of opioid withdrawal severity. And withdrawal as the outcome was captured at each of the time points. And then other factors that were captured at intake included chronic pain status, yes, no, demographic characteristics, and substance use characteristics. So now to provide just kind of some details about the sample. So again, of the 1,252 adults receiving treatment for opioid use disorder, about 70% were men. And as a quick disclaimer here, there were, in the data set, there were about 14 individuals who identified as transgender. Since the sample size was so small, unfortunately, I was not able to include them in the analyses. But the average age is about 33, and the majority of the sample were non-Hispanic white at 82%. And most of the sample reported that they were not experiencing chronic pain at 59%. And again, 36 represented the greatest opioid withdrawal severity. So when looking at the entire sample, there was about an average of 17 in terms of the opioid withdrawal severity. 86% reported polysubstance use, and about 54% reported heroin as their primary substance of choice. All right, so again, the overall goal was to look at differences in based on gender, the dichotomous format of gender, since that was available in this treatment data set. And so this graph, this beautiful graph, the y-axis represents withdrawal means, and the x-axis represents the 4 different time points. And again, that's intake, 1 to 3 days after treatment intake, 4 to 6 days after treatment intake, and 7 to 9 days after treatment intake. The blue line represents women and the red line represents men. And what is interesting is that at each of these time points, women had greater opioid withdrawal severity when compared to those who self-identified as men in this study. And so with that, I was also interested in looking at the differences between those who report chronic pain and those who do not report chronic pain. So similarly, same kind of y-axis, withdrawal means, x-axis, the 4 different time points. The blue line represents chronic pain, individuals with chronic pain, and the red line represents those without chronic pain. And so at each of these time points, those with chronic pain reported greater opioid withdrawal severity than those who did not report chronic pain. So thinking about that, so women compared to men had greater withdrawal severity. Those with chronic pain compared to those without chronic pain had greater withdrawal severity at each of these 4 time points. So I wondered what it would look like if you merge these groups together. How about women with chronic pain and without chronic pain, men with and without chronic pain as well? So same y-axis, withdrawal means, x-axis, the 4 different time points. The blue line represents women with chronic pain at the top. And basically what this graph is showing is that at each of these 4 time points, women with chronic pain had greater opioid withdrawal severity compared to the other 3 groups. However, women without chronic pain, they came into treatment with the second greatest withdrawal severity, but they had the steepest decrease in their opioid withdrawal severity across the 4 time points. So men without chronic pain represented by this green line, and men with chronic pain represented by this beautiful Baltimore Ravens purple line, had a similar decrease in their withdrawal severity. So when you look at women with chronic pain, men with chronic pain, and men without chronic pain, there was a similar decrease in withdrawal severity. So the differences are really seen from intake, and those differences stay consistent from intake all the way to 7 to 9 days after treatment intake, so about a week later. So some major takeaways from this. So women enter treatment with greater withdrawal severity compared to men. However, withdrawal decreased across all groups in a linear manner. So as a social worker and as an applied public health researcher, I always try to point to potential interventions that could reduce some of the health inequities that we're seeing. And I'm wondering if earlier treatment and barrier reduction may assist individuals with entering treatment earlier so that their opioid withdrawal severity may at least be decreased when they enter treatment. And for those groups that are identified as having an increased risk of greater withdrawal severity, potentially more aggressive withdrawal treatment. And so with that, I want to thank NIDA, thank the VISTA Research Group for data access, thank Johns Hopkins University School of Medicine, where I completed this research as a postdoc, and then thank you also to my co-authors. Now, as a statistical lover, and those who may also be in the room as statistical lovers, I also wanted to just incorporate the table from the mixed effects model. And also just wanted to say that this paper was just accepted for publication. Quick woohoo. And thank you everyone for joining me today. And I would like to open the floor now to any questions that you may have. Thank you.
Thank you so much, Dr. Ware. And so, yes, as he said, now is the time for questions. If you do have questions, if you could just put those into the chat, and we'll answer them as they come in. And so we'll give some time for y'all to work on adding those. And in the meantime, I have some questions for you. So one question that I have is, based on your research, do you have any recommendations for ways to reduce barriers amongst individuals entering treatment?
So it's really amazing because, there have been some studies that have shown that socioeconomic barriers, and then also barriers related to family care are significant issues with getting folks into treatment. So one thing that could be done is trying to incorporate family therapy, for example. as a way to kind of assist people into getting into treatment. Because that way you can still have that aspect. And there are actually some treatment facilities that allow individuals to enter treatment with family members, with young ones, to kind of have that same continuity of care, because that's also a barrier for some people entering treatment. And then when it comes to some of the socioeconomic barriers, unfortunately, treatment affordability is still an issue for some folks. So whatever we can do to kind of increase the availability of treatment for those who may not necessarily have the means or even the transportation to get to treatment, providing transportation, making treatment more affordable in areas where insurance may not cover it, for example, or finding ways for insurance to cover it. So yeah, those are just a few suggestions. I have like a million more, but I don't want to take too much time with that, but I have a million suggestions about it.
Awesome. Well, thanks for answering that. It looks like we have a couple of questions popping in the chat. Actually, so one person, if you could go back to your slide about your paper, we have a question about where your paper is going to be published.
Yes, so, whoops, went to the end of it. Okay, so that will be published in Drug and Alcohol Dependence, and it will actually come out next month. I was like, woohoo, it's coming, all right.
That's so awesome. All right, we have another question. So Hannah has asked, she said, I noticed in your last graph that the reduction in withdrawal symptoms for women without chronic pain seemed a lot steeper than the rest. And she's wondering if this difference was statistically significant, and if so, do you have any thoughts on why this may be?
So the first question, yes, the results were statistically significant. The second question, still trying to figure that out. But this is really good because this is showing that this group has some sort of protective factor that diminishes the risk of opioid withdrawal severity across the 4 time points, at least in terms of the direct reduction compared to the other 3 groups. It's something that I'm still trying to figure out. But I think that's a good follow-up study, and I'm kind of trying to parse through some of that now.
Awesome. All right. Next question. Was COWS, C-O-W-S, used with these patients to know what areas of withdrawal were most severe? And then the second part of that is, how was the withdrawal severity score described? So a 2-part question.
So the first question was, I just want to make sure I'm hearing this correctly.
Yeah. So was COWS,
Okay.
so I'm assuming that's the acronym.
Yes.
COWS.
Yes.
Yeah, was that used with patients to know what areas of withdrawal were most severe?
So the COWS, just for those who may not know, it is the Clinical Opioid Withdrawal Scale. So essentially, these data came from a treatment provider. And so the treatment provider had 9 different questions for opioid withdrawal severity. And these 9 different questions asked about specific symptoms. And these symptoms are nausea, vomiting, chills, goosebumps, sweating, hot flashes, sad, depressed, hopelessness, fatigue, lethargy. And so amongst all the 9 symptoms, they were able to rate on a Likert scale whether they were experiencing these symptoms not at all or extremely experiencing these symptoms. And for anyone who's been in like any kind of clinical setting, oftentimes what you see, there may not necessarily be a direct measure that's used. Sometimes it's used more for clinical aspects. So some private treatment providers will kind of use their own withdrawal measure. And this allowed us to look at kind of the withdrawal severity. So if they reported a symptom of not at all, that was ranked as a 0. If they reported they were experiencing this symptom extremely, that was ranked as a 4. We summed that up, and then that's how we had the overall score. However, there is a study that I'm actually working on now that uses the COWS and SOWS, the subjective opioid withdrawal scale. And the second part of the question, I cannot quite remember.
The second part of the question was, how was the withdrawal severity score described?
Oh, so they were filling this out as part of their clinical care, because this was used in a real world clinical environment in which folks were receiving treatment. We were just kind of looking at the electronic health records from a treatment provider, but this was used for clinical care and for clinical reasons. Yeah.
Awesome. We've got a lot more questions rolling in. So next question, do withdrawal symptoms generally end after 9+ days?
Typically, no, but what's interesting is that 7 to 9 days is typically the time in which opioid withdrawal severity is the most intense based on the research. So the acute withdrawal symptoms are typically experienced in that first 0 days to 9-day period. And then the severity continues to decrease. Now, in most treatment settings, especially in what's called a detox type of setting, typically it's at most 7 to 9 days. And then there's usually a next level of care that may be like a residential program, et cetera. But when someone is like kind of going through opioid withdrawal or alcohol withdrawal or benzodiazepine withdrawal, there's typically that first 7 to 9 day period that they're in a detox setting, and then they may be transferred to a different level of care. So in this setting, they were in a brief kind of detoxification service because they were experiencing withdrawal severity.
All right, next question is, was MAT, M-A-T, considered in conjunction with earlier treatment?
So this only included individuals who did not enter treatment receiving medication for opioid use disorder. And so for those who don't know, that may include like buprenorphine, methadone, and it kind of reduces the experiences of opioid withdrawal. So only individuals who did not enter treatment taking medication for opioid use disorder were included in this study. Across the sites, there was a difference in the type of buprenorphine, in the milligrams of buprenorphine that was used. But this was kind of more of looking at the aggregate experiences of opioid withdrawal. But that is a fantastic question. Yeah.
Right, and so the next question, it seems like it may be related to that question. The question is, were these individuals receiving any sort of MOUD?
So not entering treatment, but while they were actually entering, so no one who was receiving medications for opioid use disorder as they entered treatment were included in the analyses. But once they entered treatment, they were oftentimes given buprenorphine to kind of reduce the opioid withdrawal severity. And it's interesting because this was also at a time in which fentanyl was kind of introduced into the illicit substance market. And what's interesting is that buprenorphine has been shown to kind of exacerbate the experiences of withdrawal if someone is taking fentanyl. There are some new medications that are being considered to kind of reduce the withdrawal severity of people who have fentanyl exposure.
Awesome. Okay. Next question is, Nadia is curious about, I guess, if so, what clinical implications have come out of this outcome?
So the clinical implications are that we definitely need to do our best to continue to reduce the experiences of opioid withdrawal. And kind of jumping back to the last response. So fentanyl has really complicated is the appropriate word. Complicated the way that we're able to treat opioid withdrawal. So kind of identifying more ways to kind of decrease the impact of withdrawal severity. Also finding ways to reduce the barriers so that people can enter treatment earlier is another major implication from this study. Because if certain groups are facing more barriers to enter treatment, and because of that, they're more likely to have greater withdrawal severity upon treatment entry, and that greater withdrawal severity stays across those 4 different time points compared to other groups, then that means we need to do what we can to reduce these barriers so that people can enter treatment earlier and reach the goals that they would like to reach with their treatment.
Okay. So it looks like we have maybe a question related to that, but before that question, one question that we have is, did the VISTA data include any info on suicidal ideation?
Absolutely. So there's actually a second paper we're working on. It's currently under review, but the second paper is looking at the co-occurrence of substance use, opioid withdrawal severity, and then also co-occurring mental health disorders. And so we were looking at anxiety, depression, and then there's also a predictor which is included of whether or not someone is experiencing suicidal ideations or self-harm.
Awesome. Okay, next question is, so Nadia says methadone is an excellent option for fentanyl withdrawal symptoms. Did you utilize methadone?
So us as the researchers, we were just kind of looking at the electronic health records. We were looking at the electronic health records of treatment providers. So not all treatment providers use methadone. Most of the sample primarily used buprenorphine. So yeah, that's what we have there. Most of the treatment providers in the sample were primarily using buprenorphine, and we were just kind of analyzing their electronic health records. But that is a fantastic point.
Awesome. Well, that looks like the last question, which is perfect timing because that's all the time that we have for the Q&A. So thank you so much, Dr. Ware, for your presentation, and thank you all so much for all of the thoughtful questions. Are you going to show your contact? Oh, up there at the top.
Oh, yes.
Your contact information.
Absolutely. Feel free to look to your upper right and, ware@unc.edu. I'm very reachable. Feel free to shoot me an email and, we can talk and can keep this dialogue going.
Awesome. And I'm going to drop that in the chat to everyone as well. And so this concludes his presentation, and just very quickly, before you all leave, I just wanted to let you know about our other upcoming webinars for this series. And so next month, on November 9th is going to be our next webinar. That one is going to feature Dr. Joe Hart, and he's going to be presenting on some of his innovative evaluation and treatment approaches that he's used in his orthopedic work to help enhance outcomes. And then on December 14th, that'll be the last one for the fall. We'll have Dr. Vanita Embry, who will present on her criminal justice reform work that she's done with justice-involved youth. And so I'm going to drop a link in the chat to our landing page for the webinar series, where you can find more information about upcoming events. When the flyers come out for those events, they'll be on that page. And then lastly, I'm going to drop in the chat a link to a post-evaluation survey. If you all have the time, we would greatly appreciate if you could respond to it. It's super brief, just 4 to 5 questions. And this is just going to help us with planning more events that are of interest to you all. But it also will give you an opportunity to provide your email if you'd like to be added to our listserv to get direct notifications about future events. And so with that, that concludes today's presentation. So again, thank you so much, Dr. Ware, and thank you all for attending, and we hope to see you next month. All right, everyone, have a great rest of your afternoon and great rest of your week.